Welcome on behalf of HQIP and the NHS Impact team, who are jointly hosting this session today as part of Clinical Audit Awareness Week. My name is Claire Fountain. I'm the AD of QI HQIP, and I have the pleasure of introducing our speakers today. So please do introduce yourselves in the chat, and I will just briefly do some housekeeping before we get into the main session. Okay. Hopefully you should now see on your screen the housekeeping slides. Okay. So before we briefly start, I just want you to please introduce yourself in the chat. Your mics are already on mute. We would really welcome you having your camera on, makes for a much more friendly and interactive session. We are recording this session, so by staying on the call, you're consenting to that. And we will have a Q&A at the end. So please do start thinking about your questions as we go through, enter them into the chat, and there'll also be an option to simply raise your hand as well. Okay, so we have three great presenters that all link together around the theme of influencing change. There's also the session tomorrow, which will include the awards for the influencing change category and some more great speakers. So our speakers today, firstly, we are very honoured to have Elsa Brotherton, Improvement Director for NHS Impact at NHS England. She's going to give us a better understanding of the NHS Impact framework that all organisations are being asked to implement and what it takes to create an ever-improving organisation. Our second presentation is from Diane Robinson, Sam Dutton and Caroline Jowlett. And when we spoke in autumn last year, I was really inspired by the work they've done, linking to the National Diabetes Audit, and particularly how that work crossed primary and secondary care. And our final presenter is Amy Baker. Many of you may know Amy and be aware of the fabulous work that she's done in her trust, but Amy is going to tell us about how she succeeded in this work and how she is influencing and leading change. We hope to have some time at the end for Q&A, so please do start thinking about those questions. Okay. So in terms of our objectives for the session, we hope not just to hear from some great speakers, but I hope that it will help us all reflect on what it takes to encourage effective improvement across organisations and systems, what it takes to influence change and drive improvement in your organisation and beyond. And I really hope that this is a start for more conversations about how we can make sure that the highly valuable work of national and local clinical audit is a real integrated part and not separate from other quality improvement work in the future. So now I'd like to hand over to Elsa to hear about the NHS Impact Framework. Thank you very much. Elsa.
Okay, good morning everyone. It's great to be with you and thank you for that lovely introduction, Claire. I want to just talk through sort of NHS Impact, what it is, how organisations are really adopting it. Sorry, my slides are moving quite slowly. So I hope by now that most of you have heard of NHS Impact. Some of you may not have done. It is something that was launched last April, and we have been doing quite a few events where we are promoting it, but hopefully if you haven't, this morning's session will give you a good introduction. And those of you that have been involved in adopting NHS Impact in your organisations, it would be great if you could start to type your experiences into the chat box, especially around what's working well and what are the barriers, so that we can have some conversations around how we can overcome those. So for those of you new to NHS Impact, there was a review undertaken which really engaged with over 1,000 members of staff across the NHS and social care. And actually we started with the evidence base. So this review really looked at what do you need from an evidence perspective to really embed improvement across systems and organisations. And you can see here that, to get sustainable improvement, we really are looking at making sure that the quality and experience of patients and their outcomes is really improved, how we really use resources well, how we tackle health inequalities. That's something that many of us are doing now much more than we used to in our daily work. But really looking at the well-being of people who work in our system and the people who access our care. Levels of staff engagement have been demonstrated to be really key in improvement. We know that if we can train the whole workforce to do their job and improve their job, we will go on a journey to really embed improvement at every level of our systems and organisations. And then really those connections and collaborations for better outcomes. And we saw this, didn't we, in the Virginia Mason research that was undertaken at Warwick Business School, where they absolutely looked at what is it that are the core elements for improvement. So NHS Impact has 5 core domains, and David Fillingham describes these. David Fillingham, for those of you that don't know him, is the chair of our improvement board. David led the modernisation agency, has been involved in leading organisations who have embedded improvement, and he's now the chair at Lancashire and South Cumbria Foundation Trust. I'm very fortunate to work with David in our ICS, and David chairs the board. And what David describes as the DNA of improvement are these 5 components here. So really what we're aiming to do, and some of you may have been at the Confederation recently, where Amanda Pritchard, the CEO for the NHS, described our ambition, which is to become the fastest improving healthcare system globally. We've talked about this extensively in our National Improvement Board, and how do we do things really differently to achieve this ambition? And one of the key things we've been talking about is how do we all align behind building a shared purpose and vision? So that's a really key starting point. And what I would say in your teams and organisations is to maybe think about revising your shared purpose and vision as we've come out of the pandemic, and have you done the work as part of your NHS Impact self-assessment with your board to really understand what is the purpose and vision of your organisation. And then it really is about how we invest in the development of our people and culture, how we develop the right leadership behaviours. And we've been running a number of NHS Impact events. Some of you may have been to them. If not, I'll ask Hannah to drop an email address into the chat box so you can drop us a line and get involved in those. But what we've really been hearing from is some of our leading CEOs around what does it look like to get really good CEO behaviours to lead an organisation for improvement, but then what do we need to do as senior leaders and frontline clinical leaders and operational leaders? So what can you do in your roles within your organisation? In clinical audit and effectiveness, but I can see on the call we've also got some clinical colleagues with us. Actually, how do we all align behind this work? And then there's a really focused piece of work on building improvement capability and capacity. So how good is your organisation at training all of your colleagues around building their skill set, knowledge and expertise in improvement? And then there's something about, and I think this is where you have a really key role to play in improvement in the roles that you have around clinical audit and effectiveness, is how do we all build and embed a quality management system so that we bring together in a really positive way all the elements that you need to do improvement well. So how do we do the planning? How do we do the improvement? How do we really understand where we need to improve? So how do we do quality control and quality assurance well? And how do we close that loop so that the audits that are undertaken in your departments are really informing the improvement priorities of our organisations? So what we do know is that people own what they help to create. So the work we're doing in NHS Impact isn't about a few people on a board trying to design this for the whole of the NHS. This is about inspiring organisations to have the conversations to build their own approach, vision and strategy for improvement. And really understanding that real change happens in real work. And that means making sure that it's our frontline teams who are doing the work. So if they do the work, they are absolutely best placed to improve it. And what I would say is the ambition we've set is huge. So no other country is trying to do what we are trying to do at the scale we're trying to do it. And if any of you haven't read Sir Chris Ham's report, where he really spoke to many systems around how do we improve health and social care at scale, then I would highly recommend that report to you. And Hannah, I wonder if you've got the link, could you drop it into the chat box? If not, we'll provide it for you later. So what we have been doing is really focusing on what are the priorities that we need to deliver across our healthcare system. We do know we need to work well with social care colleagues too, but this really started with how can we do things differently in the NHS. And really, when we launched this in April 23, we started with a conversation with the chief executives, and that's the royal we. Amanda Pritchard launched this at one of her leadership events, and the CEOs in the room were asked to feedback. And what they talked to us about was developing a simple, jargon-free self-assessment. How do we really understand how to share the best of what we've got in the NHS? So really what underpins the work we're trying to do is learning from the best to share with the rest. And that's really where audit and improvement, I think, if we work really well together, can really make a significant contribution. But what they also talked to us about was leading by example. So really switching from performance management to performance improvement, and making sure that at every level of the NHS, from NHS England all the way down to frontline teams, to primary care, community care, mental health trusts, ambulance trusts, how do we all align behind this vision? So where we are now is that we have basically launched a self-assessment. Most organisations have now completed this and are in the process of, if they haven't already, developed a plan as to how they basically can implement NHS impact across their organisations. We're not prescribing one methodology, so you don't need to change the improvement methodology you've got, but what we are asking you to do is to make sure that all of those 5 core elements of improvement are into your approach. So just to finish off, this is the National Improvement Board. You may know some of the members. It's a really broad range of people. We have CEOs from Acute Trust, we've got CEOs from ICSs, so ICB CEOs, we've got colleagues from NHS England, we've got people who have worked out in the system and are still working in organisations who lead improvement. And I do just want to introduce Dr. Amar Shah to you all on this slide. So Amar's in the middle at the top there. Amar is our National Clinical Director for Improvement and has been leading some excellent masterclasses. So if you haven't dialed into those yet, it would be worth you thinking about doing so. So just to finish off, these are our priorities. We are just in the design phase for the first improvement programme offer, which is likely to focus on the priorities for all of us. So urgent and emergency care flow, outpatients and theatre productivity is what the feedback we are receiving would be most helpful. The design offer is just underway at the moment. Clearly, we are in an election phase, so this is, we can't actually publish anything at the moment, but the work is continuing. And what we will be doing is launching this hopefully towards the end of the summer. And what we really want to do is to make sure that if we deliver this improvement in the way that we've described, then we will be able to mainstream improvement to create the optimal conditions for continuous improvement right across the NHS. And as a result, we'll see better joint working with yourselves, but we'll also have a healthcare system that demonstrates sustained improvement in the way that we are all striving to do so. So just to finish off, we do have a driver diagram that's too small to see on screen, but we will share it with you afterwards. And then really what I wanted to do is to finish off by saying there are a number of NHS improvement events. So there are some lunch and learns and masterclasses. You'd all be very welcome to sign up and join those. So we will make sure that you get the dates. And really, if you want to find out more, then do go to the Futures website. There's lots of case studies and examples of how other places are doing this. And I just wanted to really urge all of you to get involved with this work. Thank you very much, Claire. That's all I wanted to say.
That's brilliant. Thank you so much, Elsa. You talked about inspiring us, and I think you have, because it's it's about us all being change makers, isn't it? It's about us seeing that actually an organisational wide approach needs to really have clinical audit at its heart. And this is Clinical Audit Awareness Week. So, let's really make sure that we raise awareness of how important clinical audit is as part of that quality planning, quality improvement, quality control system. So thanks very much, Elsa. If you have questions for Elsa, then please do start entering your questions into the chat and we'll do a Q&A. And if you haven't been involved in this work so far, this is really a prompt for you to find out more and to find out what's going on in your local organisation and how you can start being part of those conversations. Okay, so on to our next speakers. So Diane, Sam and Caroline, please tell us about your diabetes work.
Morning, everyone. So my name is Diane Robinson. I'm a clinical projects manager with the North Eastern Yorkshire Physical Health and Prevention team for NHS England and focusing on diabetes. And later I'll pass you on to my colleague Sam Dottin, who is an NDA engagement lead with Diabetes UK. Caroline, I don't know whether or not you just want to introduce yourself.
Yep. Hi, everyone. I'm Caroline Jowett, and I'm the Clinical Programmes Manager responsible for diabetes and obesity in the North Eastern Yorkshire region. But Diana and Sam are going to take you through the work that we've done and that we're really proud of.
Thank you. So the ask of us was one of the national priorities was for ICBs following the pandemic to look at the recovery process of the 8 care processes and 3 treatment targets. And we knew during COVID, obviously due to the pandemic, there'd been a significant decrease in the completion of these. We also knew that ICBs were facing additional challenges as reduced funding was coming through for diabetes. So the money that they did have, they needed to be quite focused and careful with how they were going to use that remaining funding to get the absolute most out of it. We were already looking at the various data that was available to us for diabetes, and we knew that the NDA was publishing some really great dashboards, and we're doing a lot of work on making improvements to those. And it became apparent to us very early on that ICBs could use these independently to sort of help them with their planning. So our role really was to support them in raising awareness of the dashboard, so ensuring that they knew that these dashboards were in existence, that they could use these dashboards and that they could use them to help with that planning. So we did this in twofold really. So the first thing we did was we actually used the data to create some personalised data packs for the systems, and this was to demonstrate the information that we could actually get out of the dashboards. So the data packs included information on the 8 care process completion and 3 treatment target achievement, and it showed that improvement since the pandemic. So each pack was designed to tell a story. So it had data from region level through to ICB, to place, to PCN and practice. So you could see all stages and all levels, what that recovery looked like. We displayed that in a very visual form. So they were all in graphs, so you could see very easily whether or not recovery was happening or not. And we also included then using the data and in an analysis of what that data was telling us, so that somebody could pick it up and actually look and see quickly what was, what was happening at any of those levels. We also then ran a NDA learning event. So we worked very closely with the NDA team and Diabetes UK to deliver a learning event. And the purpose of that was to demonstrate what the dashboards were, how you could use them, and we did that using a real-time scenario. The event was really helpful because it helped us gain an understanding of how and why delegates were using the data, so that the NDA team could then take that and use it to make improvements going forward. But it was also a real opportunity to get a sense check from the audience of whether or not the data was actually telling the story that they thought they were seeing actually on the ground. And it was really reassuring to know that actually, yes, that was the case, that it was telling them what they already knew, but it gave them the data to back that up. And it was also an opportunity for us just to ask whether or not they had any other requirements of the dashboards that those could be built into future releases. So the impact that had was the data packs. All systems really gratefully received those data packs, and I think it really highlighted actually they could go away and do this themselves. Humber and North Yorkshire ICB took this one step further, and they had theirs professionally printed, and they used it at a 3-day face-to-face diabetes nurse event, just to sort of highlight to them what recovery was looking like or not. The learning event was really popular. We had over 200 people registered to attend, with a mix of roles of people attending, whether that be ICB, primary care, secondary care. Of the feedback we received, 100% said that the event met their expectations and they would like further training, and gave us some examples of what they'd like that training on, so that we could tailor that for them. For both of the things that we did, the sort of reoccurring theme, if you like, through that was that services were continued to improve following the pandemic, which was great, but that they also were acknowledging the importance of data to help them demonstrate that. So in summary from me, we managed to achieve that ICBs recognised that data is a game changer. That ICBs understood that the dashboards are easily accessible and usable, that they can use these dashboards alongside their own local intelligence, which can be more real time. But the work has promoted independence in ICBs using their own data and using that data to answer questions, whether that's to build business cases or just to reassure them that the work they're doing is actually going in the right direction. I'll now pass you over to Sam to tell you about her role.
Hi everyone, I'm Sam Dottin and I work at Diabetes UK and I'm the NDA engagement lead. So firstly, what is the NDA? The NDA is the National Diabetes Audit. It happens by all the data from diabetes care being pulled together and cleaned and made sense of by NHS England. We then look at that data and create reports on it and look at and that allows us to look at if there's any particular trends, what's improving and what's not improving. So that will help services to shape their future work. The data covers England and Wales, and we actually run a series of audits under the name of the National Diabetes Audit, and that includes foot care, pregnancy, young type 2 diabetes and the care processes. And we also run a quality improvement programme as well. So what we're really wanting is that people to use the NDA to support your service and to improve what you're doing. In terms of who's involved in the NDA, we have healthcare professionals, we have people living with diabetes, NHS England, HQIP and Diabetes UK. And what's really great about that is everybody brings a different perspective and we look at those perspectives to help shape the recommendations that are coming out from the findings of the audits, and that helps to keep things realistic and impactful. So we've got healthcare professionals there telling us what's happening on the ground. We've got people living with diabetes explaining what their experiences are like and what they would like to see changed. What we're recommending or what we're asking you to do is to really understand the NDA, check out the web pages, understand what we do. They're on the Diabetes UK website. There's also our NDA reports, and then there's information about our quality improvement work as well. And then I think that the key thing is I've been out to conferences and heard people say, oh, I don't want to see what's going on. It's going to be bad and we're going to get in trouble. Let's look at it glass half full. It's a carrot, it's not a stick. Knowledge is power. Once you know what's going on, you can then celebrate those good things, but also look at how you can make improvements, just like Yorkshire and Humber have. We have worked with Yorkshire and Humber to as Diane said, to create that webinar event, but we've also created some with NHS England. So we've done a foot care one. So we can I can send the links, I'll put that in the chat for the videos for that. There's also the opportunity to get involved in the quality improvement collaboratives, which are great, and they cover England and Wales as well. And that is real peer-to-peer support where you're sharing resources, talking about difficulties that your service might have, share that with others. They might be in the same position as you, or they might have a solution. So it's a real great opportunity for services to come together and just work together, and it does make an improvement, which is fantastic. And then just contact us. We're here. If you've got any questions, if you want to know how to use the dashboards, then please do contact us and work with us to make improvements. Thank you.
Brilliant. Thank you so much. And what I think is great about what you've done is and sharing a link to the dashboards themselves will be great, because when you look at the dashboards, I was really impressed how actually it's one of the areas that goes across primary and secondary care. And that's one of the strengths of that audit, which is great. And the QI collaborative stuff is really at the heart of it, isn't it? So yeah, really thank you very much. I'm sure there'll be lots of interest and questions after today. Okay, so please do continue to enter your questions in the chat. We will try and get through as many of those as possible, but we can also engineer an introduction to you, to the speakers after the session, should there be questions that we need to take away from today. And I'll move on swiftly to our next speaker. So Amy, tell us about your role as a change maker and inspire us all.
It helps if I unmute myself, doesn't it? It's not a good meeting without a tech support issue. Everybody, good morning. I hope you're all surviving the heat a bit better than me, apparently. So my name is Amy Baker. I'm the Patient Outcomes Manager here at Cambridge University Hospitals, or CUH for short. I'm taking a different approach today. Some of you may have seen my presentation before. If not, I'll be talking about it just very shortly on the next slide. But for those who have seen it before, the slightly different turn today is we're going to be really talking about the sort of people, mindsets and engagement behind the development of the National Data Project that we won the award for last year. So I'll move on to that now for you. So the team and I were very lucky enough to have won the Influencing Organisational Change Award last year. It was like a co-win. We were very happy and excited about it. And the work that we did behind it was we developed a database that helped support hospital level data, so our data here at CUH, but in a very simple way that allowed our team centrally to see trend and tracking information historically, but also things like, are we better, same or worse than not only our peers at other hospitals, but also nationally. And it was a really interesting development. And I think talking about the people and the way that we proposed that bit was something we've actually not had the opportunity to do today. So I'm very grateful actually to be invited to speak. So I'll just move on to the next one for you all. Here we are. So one of the questions we got asked was, how did we create the time and the focus for the development of the project? Because we all know it's not easy. We've all got deadlines to hit and business as usual to undertake. But how did we make the time to create this sort of like change the project? Well, one of the big things that we saw was we found the gap of it. We really just saw that first, and we asked ourselves as a team, actually, how could we make this better now that we found this missing data sort of across things? And we realised, well, we had good governance reporting, but it could have been better. So we really wanted to just find out what we could do and how we could do it. Now, I'm not saying balancing it alongside business as usual wasn't a challenge, but we really just made it a focus and a goal for ourselves to create this and fill in that gap so we had something. The other thing that we had was, as a team, when we were just sort of like developing this, taking it forward, which is a line that my team know really well, is we created a space safe to try. And that's to try, to fail, to learn, to change. Because we went through, I think, gosh, it's on version 5 now, I think, this database, but there's 5.1s, 5.2s, etc. So we need that. And I think that's one thing that a lot of people perhaps don't think about, but giving your team a way to try something and letting it fail and learn from it is actually huge, because that's how you get your new versions. Because our database started as just a very small bar graph, I seem to recall, and now is this wonderful big sort of dashboard with all this national data. And I know that was the team's big thing, was just giving them that reassurance that whatever we did and however we tried this, we could keep trying again until we got to the end result that we wanted, and that suited obviously the hospital and the trust when it went sort of further up. As we developed this internally, we started to bring it up to more senior managers as well, show them what we were planning and what we had in mind and were developing. And then we started getting more senior backing as well. And that was a really good feeling. So once we got that sort of tie-in, it sort of started spreading and filtering down through other channels as well. And then we started bringing it into further things such as our strategy. So linking it to local priorities, because that was obviously a big thing with, again, once this started filtering down, is the one thing I want to say alongside that safe space to try is we really chose to make that change. We chose to go out of our way, and we understood our business as usual and that we'd have to keep that up. But we wanted to fill that gap. We wanted to take that time to make that improvement and make it better. I'm very lucky as well. Our team are very, very good at Excel and other things, but also we just are very big on lean and like streaming work streams. So having that in mind while we were developing was a really, really good thing for our team. And I think just bringing that together really brought the team together as well and gave them something really to focus on and something to be proud of and showcase together. So having that sort of like piece of the team really set us up for the engagement further on, because the team was so passionate about it by this point that obviously going and talking to other people and getting backing became so much easier, because they were like, let's show you what it can do. It's going to make your lives easier, that sort of thing. And that was the goal, really. We really wanted it to just be better and be easier for staff. And that was the big goal. So I'll just move on to the next slide here. With that sort of understanding of the bigger picture, and again, what we could provide as staff members, because we're only a small team. There's only 5 of us here at CUH. So it's not like we've got this massive team to support this. It was just us going through. We created some non-negotiable golden rules during our development. And this was sort of before or when we started taking it out to the engagement side of things. Now, these golden rules, I mean, were very, very simple. We just wanted to keep it as simple as possible. Now, below here, I'm not sure if you can see my mouse, but I am sort of hovering between the two. We've got these just 2 very simple traffic light systems. And that was sort of how we wanted the data to view. So we've got all this lovely complex data. We've got graphs that will tell you everything. But the basic thing that we're viewing are these 2 bits below. And people can just see in a very simple traffic light system, are we doing better, same or worse, or not met or met? That's particularly ones for like SNAP. I'm sure you've all seen the sort of data that comes from that, where it's like you might get a yes answer or things like that. So having that simplicity was what really as well got the clinicians behind us, because they don't have the time for anything complex. They need things that are going to save their time in the long run, which was really, really helpful for us. I think the other thing as well was giving the clinicians a chance to understand that we were looking at this from the point of view from patient outcomes. That's been part of our strategy. That's something we've really modelled. And we wanted it to be a way that they could see those patient outcomes changing over time. This wasn't just a, oh, have you done the report? Oh, can you come talk to us about the report? Blah, 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 and a bit about that. It's actually created a lot of engagement. And I think that was one of the big things, was this cycle that we had with them. So we were taking development sort of updates to them about once every quarter, letting them provide feedback, seeing perhaps what we were missing and what they needed or felt like they needed, and then going away and developing and coming back. And that created engagement because we really got what they wanted, but also still met what we needed as well. So it became this really intrinsic project between the clinical staff and our team, which was just a fantastic thing to work together with so many people on. So over time, we've obviously developed this and it's gone out to clinical teams and been embedded. And some of the feedback we sort of had, I've put up here in some of the circles, but I'll just talk through briefly, is one of the things is that the data has created improvement and transparency. Nobody had the chance to see this data as it was before. We currently have about anywhere up to 5 years of clinical data in there where we can for hospital level data. So people are, again, seeing that trend information. One other really interesting thing that it's created discussions on is obviously the impact of the pandemic on our data systems. So that's been really interesting. Healthy discussions and competition. Competition, I don't even need to say, I don't know how anybody else's hospital was split. We have lettered divisions here like A, B, C, D, and it just creates a little bit of friendly competition between them to what they're doing. But the healthy discussions, the discussions again have veered far away, which is something we've been working on for years anyway, from, you know, like, oh, have you completed the project? Have you given us the report, the action plan, etc., to more actually, Do we have enough nursing whole-time equivalents? Do we need a new MRI machine? Do we need a hospital surgical robot? What are they doing that we're not doing? Does this team have a completely different way of working? And it's completely changed that sort of clinical space, and people are sharing more and more ideas more frequently, which is absolutely fantastic. It's also improved our reporting with the shared governance channels. We are taking this as a live database now to any sort of like governance things, and also reports, committees, etc. We can just take screenshots of it. So we are having really transparent data. Our dashboards are also split into different factions. So we have like one just for the divisions, one just generally looking at the audits, one for the actual trust as a whole. So people are really locked into seeing the information that they want to see. And that's really helpful too, because nobody's having to dig through hundreds of sets of information to try and find one thing. They can kind of see the overview and the deep dive of the data that they need. And that's been really helpful. And I've sort of touched it already, but the collaboration, like I know this extends to wider than just our trust. Again, like I said, we're viewing this in terms of us with the national standard, but also us versus the national aggregate, which is generally like the national average of everybody. But also, you know, with things like model health system, etc., we can really see as well, compared to certain particular peers, especially a trust our size, something like the Shelford Group, we can really see exactly who's doing better than us, but also we can approach them now and see like, right, okay, so you're doing better than us, but what are you doing differently? Can we have a look and see? Do you want to share systems? Is there something we're doing better than you? People are approaching us more as well. I do find it's really set up this sort of national networking more. And if anybody would like to, I'm always available for conversations and chats on Teams, etc. So you're more than welcome to get in contact. But I think it's just created this real harmony between like the clinicians and this data, and also I think just taking a bit of a weight off them by making it a more central resource where they can see exactly that trend information. And that's been, I think, one of the biggest things that's come out of it for them. So on my last slide here, now I know any questions is coming in a minute, so I'll leave it to that sort of point. I don't put this in by accident, but just to say to everybody here, if you want to see the actual case study, there is also a YouTube video and a case study that was written up about this project. And again, you can always contact me as well, but I just want to say, if you're trying to develop anything new, give yourself the safe space to fail. It's the biggest thing that you can do, and then just try and get everybody on board. Be proud of your work and go forward, and that's the best thing you can do.
Brilliant. Thank you so much, Amy. It's brilliant. It's a great example of a team that are not just sitting back and saying, well, we're doing all the things that we're being told to do, but you're thinking, how do we make it better? How do we make it easier for people to do what we want them to do, which is to really own that data? There's so many things. I just, you know, really pleased that everyone got to hear that perspective today. And I'm hoping now that you've got all that data together, it's really doing what Elsa was talking about, which is helping to drive those priorities and helping to inform those, but just changing the conversations to being really curious and joint collaborative conversations with clinicians. Fabulous stuff. Brilliant. Okay, so lots of stuff going on in the chat, which is wonderful. And okay, slides have come down, which is fine. So we'll now have a bit of Q&A. So please do enter your questions in the chat. You can also raise your hand if you'd like to ask a question directly. It's helpful if you say who the question's to, but we'll work it out if not. And just while we're kind of looking at what's in the chat and what themes are coming through, I'll just kick us off with one quick question. So quick question, it may not be a quick answer, we'll see. So question is to Elsa. So at the beginning we talked about, you know, how clinical audit really needs to be an integral part of an organisation's approach to improvement. And obviously you have another hat where you are an improvement director within an organisation. So, you know, building on, I guess, the messages that Amy mentioned around kind of leading change, is there any advice that you would give to clinical audit and outcomes teams of how they can make sure they're part of those conversations about the overall approach?
Yeah, absolutely, Claire. And I should maybe share with you that in a previous role, I did have clinical governance and audit in my portfolio. So I am a big sort of fan of the work that you do. It's just great. Without audit, we really don't have an opportunity to really understand where we are and be able to benchmark and then be able to see where we need to improve. So, you know, massive thank you for all of the work that you do. I think what I would say is go and have a coffee with your improvement team. So if you haven't connected with them yet, give them a ring, pick up the phone, don't send them an email. We do lots of, well, you can to do the introduction, but have a conversation, because actually when you build relationships, I often say that improvement is a team sport. And actually what I mean by that is you need every member of the team. And there was a great question that we might come to later on patient co-design and engagement, because I include patients and the people that we serve as part of that team. But actually go and have a conversation and just start to talk about the work that you do and understand the work that they're doing. Because actually, you know, if we work really well together, you will be able to raise the profile of the work that you do in clinical audit, but you'll also be enormously helpful in terms of identifying what the organisation's priorities are that the improvement team should be focused on. So we work very regularly with our sort of both clinical governance and audit team in particular. And actually, Stuart in my team has lots of conversations. So I would get somebody who is responsible in the improvement team for making sure that you are incorporated into setting those priorities. And Amy, your presentation was brilliant. If we could bottle your passion and enthusiasm and just share that, it would be fabulous.
That's very kind of you. Thank you very much.
But actually, you know, you talked a lot there about the core things that we need to deliver improvement. You talked about it being safe to fail, which is really, really important. You talked about making it easy for frontline staff to do the right thing, another core part of improvement. So actually, the work that you're focused on is very similar to the work that improvement teams are focused on. And if we connect together, then actually it just gives us sort of a much stronger voice and a much greater ability to be able to promote both the work and contribution of audit and improvement.
Fantastic. Great, thank you, Elsa. And while we're with you, Elsa, one of the first questions that came in was around patient co-design. So we know it's an integral part of all national clinical audits, but how does it fit in terms of the organisational approach?
Yeah, so one of the things that we've been reflecting on as the NHS Impact team, and we have had some feedback from some of our very early consultation around actually, you know, could we incorporate patient co-design into one of the 5 core domains? The core domains were sort of produced as a result of the review that was undertaken. So we don't really have an opportunity to go back and include it in the original 5. But what we have absolutely committed to as a National Improvement Board is making sure that we are really working in a co-design and co-production way. So we've had some conversations as a team about can we make sure that we've got a member of the board who is sort of representing sort of patients and patient groups. That is quite difficult given the wide, diverse group. But what we are doing is making sure that we talk to teams about having co-design and co-production. Different people use different terms. There is actually a distinct difference between the two. But actually, whatever you use in your organisation, it's absolutely fundamental that patients are involved in the design work. And you know, we do that here in my organisation. So we use something called the Flow Coaching Academy. We have patients in every single one of our big rooms designing the work with us. And I can honestly say that every improvement project or programme I've been involved in, the contribution of patients always makes us do different work. So actually, I'm just going to share an example with you from the National Improvement Board last week. Some of you will know Bob Claber and his work. He does some brilliant work, lots on kindness. But actually, what he was talking to us about last week was the benefits of listening to patients. And he shared with us, and I hope Bob won't mind me sharing this with all of you, I'm sure he won't, but actually, they had a patient sort of group in their hospital, and he was basically saying that the gentleman who chaired that group started by saying, how different would it look if we could value patients' time? And Bob went on to explain to us how that changed the conversation, and it actually changed the conversation in our improvement board last week. So I think, and thank you for the question, I think the more we can do to really understand what matters to our patients and actually making sure that everything we do adds value to the patient, then the better and sort of greater the improvement that we deliver will be.
Fantastic. Thank you, Elsa. So I'm just looking through the chat. Has anybody got their hands raised who would like to ask a question? Can you see any particular questions? Or okay, we've got a hand up from Carl. Welcome, Carl.
Hi, thank you, and thanks for organising this session. Great to see 200 people online discussing quality improvement and how we all work together to take it forward and continuous improvement. Yeah, so I was just going to share my own reflections from our experience in Leicester. Before we had a separate clinical audit team and a QI team, and over the last 2 years we've merged together and we're working together now because and we've got an audit and quality improvement program now, because whilst we've always used clinical audit as a quality improvement process, addressing wicked issues and where we don't know the answer to the problems is quite hard to do through the audit cycle atypically. So what we do now is do the audit, find the gap to standard, and then if it's we know how to do that, we just need to follow the guidelines or just do it type of thing, then that's easy to perhaps resolve. But if we don't know why there's a gap to the standard, we then use more sort of complex QI methods, shall I say, to try and find the root cause of the problem and put in solutions to work. So I certainly, commend what was just been said about continuous improvements. Everybody's responsibility in the organisation. It's not just the experts, and it's all about trying to do those little things in terms of seeing a problem and doing something about it, isn't it? And it's trying to work together, in terms of priorities and addressing the key things, that because you can't, improvement's hard and it's hard to do it, so let's prioritise and work together.
Brilliant. Thanks, Carl. Absolutely. It's all about bringing it all together, isn't it? And have we got any other hands up? So, Elsa.
Yeah, Claire, I just wondered if I could, Carl, just say that's absolutely brilliant. Can I ask you to do something, Carl? We at NHS Impact are busy collecting case studies of examples of excellent practice, and that sounds to me as though what you've done. Do you work in Richard's organisation? Richard Mitchell, yes, yeah. So Richard's on our National Improvement Board. I had the privilege of spending a day with you all in the East Midlands for your NHS Impact Day, and I was blown away by the work that you're doing over there. Would you work with Hannah to do a case study for us that we can share both with the improvement community and the clinical audit community? Because I think that's a great way forward, Carl, and if more of us can combine those teams or find a really good way to integrate, that would be fab. So if we can collect from you that work as an example case study, that would be really good.
Yeah, we met with Dr. Amir Shah recently, and he gave us the thumbs up and said, let's scale this up now. You've got all the all the structure in the right place. It's just ready to roll out, and it has exploded a bit now. We're inundated with projects. We always had great in clinical engagement, but it's even further now in terms of doing that. So yeah. No, yeah, certainly happy. Yeah,
that's fantastic. And Claire, if any other colleagues on the call are doing something that you think you'd really like to share with us all, can you just drop Hannah an email and we'll send you the template, because the more we can share, the better.
Absolutely. There's so many examples of how clinical audits, local and national, have resulted in wonderful improvement work. And as Elsa says, the more we can share it, the more we can show that actually it's a different way of just achieving the same goals. And that really comes back to having that coffee, isn't it, with those QI teams and saying, well, they might be experts in lean, service redesign. Clinical audit teams, clinical effectiveness teams have wonderful experience in engaging with clinical teams, in robust data, in evidence-based data. And sometimes the QI teams can be very extroverted and very bouncy. But actually, if you meet them for a coffee, you'll see that you have more in common than you think. And actually, you're all trying to achieve the same things. This time last year, we did a masterclass called Clinical Audit and QI, Dancing Partners or Strictly Rivals. And, it's the same, it all needs to come together. So wonderful, wonderful discussions. There's another question for Elsa. Elsa, you seem to be getting all the questions today. So similar to the patient experience and question of patient involvement, what about charities and other organisations? How should organisations be linking those types of organisations into their improvement approach and how they set improvement priorities, for example?
Yeah, that's a great question. And I think, again, that's a case of having a conversation locally. So we've been doing quite a lot of work on this because we recognised as an organisation, so I'm now talking about LTH, obviously, rather than NHS Impact, that we don't necessarily use and work well with all of our voluntary and faith sectors and charities. So I think, having a conversation about what is available locally and how you can better engage. So there will be people in your organisation who are looking at this. So again, I would just find out. So just have a conversation. If you're not sure, then maybe, contact somebody in your organisation who heads up your hospital charity. That's always a good place to start, because they often have connections into other charities. But just think about, and I think this goes for, lots of the work that we do. We quite often talk about the phrase at the moment, shift left. I don't know whether you're using that in your world too at the moment, but that really means, how do we provide the care before people get into our acute services? But really, if you're in a community service, how do we support people to live well and independently in their own homes, with the community groups that are available to support them? So again, I think it's around, and the other thing that we've done is we've just spent a little bit of time. So we have one person who now represents our voluntary sector who we can go to. So there is probably somebody in your integrated care system who's also really leading on how we work together as a whole system. And it may be worth you just having a conversation with those colleagues too, just to sort of see what is available in your local area. But it's a point really well made, because our charities are able to really support the work that we do in a way that I think some of us haven't historically explored.
Fantastic. Thank you. And there's a couple of different comments in the chat that kind of illustrate that it can be even more challenging to do some of this stuff in ambulance sector and in that community sector. And there was a question in there for the NDA team asking whether you've engaged with some community trusts and whether you could share some case studies or examples, either now or offline, to help those organisations. Sam, did you want to answer that one, or Diane?
I'm happy to start, and Diane, you can chip in if you want to. The NDA has been running for like 20 years, so there's a lot of information out there, and in terms of quality improvement work, it's been growing as the years progress. So it started off with doing like a piece of work on pregnancy, foot care, for example, and having, say, 10 to 15 different services involved in each of those programs. Now we're working on a project which is focusing on type 1 and technology, and supporting services with how they make that offer, especially with the change to NICE guidelines. So it's been really well timed that piece of work has happened at the same time. So we've been able to go back and ask questions, get clarity, support with people, and just trying to find their data, know how to look at it, and then kind of prioritize who they want to work with, in terms of patients, because there's going to be a big piece of work around offering technology, and then kind of everyone sharing resources around what that, how they can help each other. And we're also now looking at doing an even bigger piece of work around type 2. So we're just kind of scoping that out and seeing what that might look like. So there is a lot there. We've got some when I first started, so I started 2.5 years ago, just sitting in on those sessions. It was really inspiring to see when people come together and they collaborate, and just having that safe space to talk and having that space to kind of problem solve together and give recommendations and say, oh, we tried this, it didn't work, so don't go down that road, or if you are, then maybe think about these things. It's like I said, it is inspiring to watch that play out, and then the passion as well of everyone that's involved and how they go above and beyond, working in their lunch times, doing all kinds of things, and then seeing the results at the end of it and just really celebrating that. So the QI work as well as the audits they're massive pieces of work, but really do make a change. I don't know if I answered the question.
Yeah, so you're doing a lot across a lot of different areas. And I think what's really great is just that by having these conversations, people are aware of the sorts of things that are going on, and they can have a conversation to find out more and see how things might either be used or be adapted for their own context, which is great. Okay, we have 3 minutes left. So Caroline, did you want to add to the last bit?
Yeah, I
before
did.
I move on?
I forgive my poor network quality as well. If I look a bit jerky. I think when we talk about co-production, bringing patients in, making it a team effort, I think the diabetes example is a great one, because we are working as an NHS England team. We're bringing system colleagues together across the ICBs, and bringing Diabetes UK in and the NDA, and the amount of consideration and work that is undertaken to understand whose priorities and how we dovetail those priorities in together so that we can create improvement. I think it shouldn't go undervalued. So and then when we bring patients into the mix, because it's absolutely right, the people who are experiencing those services are the best people to try and create that improvement, I think is another essential piece of the jigsaw.
Yeah, that's great. Thank you, Caroline.
Can I add one more thing? Sorry. A new piece of work that we've been doing in the NDA is these messages called Do One Thing, and they are aimed at multiple levels. So we've got messages for policymakers and commissioners, we've got messages for healthcare professionals, and we've got messages for people living with diabetes, and they are shaped to really make an impact. And the messages are, you know, with everybody on the advisory groups for the NDA, they are shaped by them looking at the findings and our recommendations, and they're very simple, but again, it's that whole collaboration of everyone coming together to do something to make a difference. So I just wanted to put that out there as well.
No, thank you for doing that. I'll make sure that we pick up on all these wonderful things and make sure that the salient points and the connections and things are made so that the NHS Impact team know about these things, but also we can share them more widely through the NQI network and through our HQIP communications. Okay, we are in the last minute of the session. If anybody wants to speak now, then now's your time. One very quick question then from me, if there's nobody else. So Elsa, you know, you're obviously very supportive of the work this community does. Thank you very much for that. But the big elephant in the room is productivity. How do we make sure that we keep clinical audit at the top of the agenda?
I couldn't possibly do that justice in 1 minute, Claire. So why don't I commit to having a further conversation with you and making sure that we stay connected as two communities as we go forward, because you're absolutely right, that is going to be key. And one of the things that Sir Chris Ham said in his report is that we need to create, as leaders and, you know, frontline leaders, we need to create the hope and belief that we can really improve. And I think what I've seen this morning is absolutely evident. I mean, the work that you've described from an NDA perspective is fantastic. There's some key lessons there. And I wonder whether, as an output of this work, Claire, we should get together for a follow-up conversation that says, how do we really plan? Because it strikes me that you've got much more to offer than just being part of a quality management system. Let's actually have a conversation about how our teams work together to be able to take this work forward.
That would be fantastic. So, I mean, in the last minute, of course, you know, we can't solve everything, but again, it's a start of a conversation, and we have the NQI community, which is all you brilliant individuals. So let's, and I can see Vicky on the call nodding. So yeah, let's make this the start of the conversation and keep things moving, because we know lots of fantastic work is going on. So thank you very much, everybody, for being here today, for sharing your knowledge and experience. If we didn't get to your question, I'll be going through the chat with a fine-tooth comb afterwards to make sure, but also to package up some of those case studies and make sure that we share those widely. So thank you very much again to all of our speakers. Really, really motivating and brilliant. So thank you. Big round of applause. And let's keep collaborating. Let's keep talking. Thank you very much, everybody.